Hello and welcome to the Biology of Cancer. In this section, we are going to go back and use some of the information that you learned previously as far as cell biology and altered cell biology and see how those concepts are going to cause the potential for a new growth in the body, an abnormal new growth, and we call that cancer. Now, hopefully this will be a review of the content you've already read in your book, but which of the following cancers arises from epithelial tissue? Is it sarcoma, glioma, carcinoma, or leukemia? Well, hopefully you were able to pick the correct answer. It is a squamous cell carcinoma. And our next review question is, which of the following cancers arise from connective tissue? Is it a lymphoma, glioma, adenoma, or sarcoma? Correct answer is sarcoma. Next, which of the following cancers arise from bone marrow stem cells and always originate in the bone marrow? Is it a glioma, lipoma, leukemia, or lymphoma? Correct answer is it's a leukemia that always originates in the bone marrow, and arises from bone marrow stem cells. Leukemia arises from having an overproduction of immature white blood cells in the body, and this will cause multiple problems with our patient. First of all, immature white blood cells are white blood cells that are immature, so they're not able to fight infections. So we'll have infectious problems. We'll also have problems with having too many white blood cells on board here. So we see things like weight loss, fever, frequent infections. Those are systemic things listed on your diagram here. Shortness of breath, possibly muscle weakness, bone and joint pain and tenderness, psychological fatigue, lymph node swelling because we're getting all those white blood cells collecting inside those lymph nodes and starting to make them swell, enlargement of the liver and spleen for the same reason, and lots of other symptoms on the skin. So this is just kind of an overview of some of the symptoms you may see in patients who have leukemia. A neoplasm is a new tissue that has been formed for some reason in the body. Now, what can happen in our patients that develops cancer is that the patient is developing this new tissue that is not a functional type of tissue in the body. There's a number of different ways that this can happen. One way would be that the cells around this particular abnormal cell don't tell it to stop dividing and to stop getting bigger, and so this tumor starts to form and starts becoming bigger and bigger. Oftentimes what will happen is that when cells divide, when cells are replicating and we're getting two daughter cells, there could be some problem that occurs with that division, with that replication. And when that replication problem occurs, it can lead to a different type of cell being formed. Normally, the body is going to sense this and the body is going to get rid of that abnormal cell. But if that abnormal cell is pretty close to the original, it could be close enough that the body doesn't sense that it's abnormal. And then what will happen is that that cell could continue to live, and that cell may be able to continue to divide and cause new cells to be formed and form into a mass, and that's what we call cancer. Another situation where the patient may develop a neoplasm would be if we had apoptosis kind of a situation that was not occurring. Now remember, apoptosis is a situation where cells normally die off and are replaced by new cells. For again, as an example, your skin cells die off, new cells come in, so you have nice healthy skin. Otherwise your skin would age very quickly as the cells that are sitting there start to age. So normally the number of cells that are in the body at any one time is going to remain rather constant. We have cells dying off from apoptosis, and we have new cells being developed to replace those cells that have died. But we're usually not developing lots of new cells in a specific area of the body that are not replacing cells that have already died. In other words, if that number of cells becomes more than it's supposed to be, then we can have a new growth or a neoplasm that is formed, and this could be something that could be cancerous. So what makes the difference between just an overgrowth of tissue and something that's cancerous? So we could have an overgrowth of tissue, and typically we would call that a benign tumor, or we can have something that's cancerous, that's a malignant type of a cancer. One of the big differentiations between a benign type of tumor and a malignant type of tumor is whether or not it's going to invade other organs or travel to other parts of the body. So this tissue overgrows and it forms into this new growth, that neoplasm we call cancer. Not all tumors or neoplasms are cancer. They could also be a benign type of a tumor or an overgrowth that is just removed and doesn't cause any further problems for the patient. So cancers are tumors or neoplasms that are malignant. So we term them as cancer if it's a malignant kind of a tumor that could be causing additional problems. Tumors are going to be named after the tissue from which they arise. For example, oma, the tissue oma, or the suffix oma, is going to be applied to brain cells, for example. If it's coming from the brain, it's going to be called a glioma. If it's fat cells, it's going to be called a lipoma. And then if it's a cartilaginous tumor, it's going to be called a chondroma. Well, we began with some questions about these different types of tumors, but let's continue on with them. And of course, we have the epithelial tumors, which are, for example, they're called carcinomas. And for example, one type would be an adenocarcinoma. This is a carcinoma that is occurring within the lymphatic system, and so we call it an adenocarcinoma. Connective tissue tumors are called sarcomas. So rhabdomyosarcoma is one example of a sarcoma of the connective tissue. Lymphomas occur in the lymphatic system, so we call that a lymphoma. Cancers of blood-forming cells are called leukemias, typically affecting our white blood cells. And then cancer or carcinoma in situ would be malignant tumors of the glandular epithelial origin that have not quite gone through the basement membrane to really establish themselves as a tumor yet. But it's a tumor forming in the tissues of the body, but it has not yet formed so that it's grabbed a hold of the underlying tissue and could be causing problems for the patient. So I've alluded to the difference here between a benign and a malignant tumor. Let's take a look at this in a graph style, so hopefully we can be able to compare this a little bit better. So benign tissues grow slowly, as opposed to malignant that grow rapidly. So a benign tissue may take years and years and years to form, whereas a malignant tissue may only take a few months or weeks to start forming that malignant tissue. A benign tissue is usually well encapsulated, whereas malignant is not encapsulated. So in other words, the benign one might look like a softball, for example, because it's very well encapsulated, held together. All that abnormal tissue, that new growth, is held within this capsule. A benign tissue is usually not invasive, so it's not invading other organs or tissues around it, whereas malignant tissues or malignant cancers are. They're usually benign or well differentiated, whereas malignant type of tumors are usually poorly differentiated, which means the cells have not differentiated well among themselves. There's a low mitotic index in the benign type of tumors, where there's a high mitotic index in malignant, which means they're going to reproduce more rapidly and cause a bigger tumor or cause a spread throughout the body a lot more quickly. Malignant tissues or malignant cancers are also going to metastasize, whereas benign tumors do not. As was previously mentioned, tumors are named based upon the tissue type that is of origin, and then we add oma to the end of it to indicate the tumor or the cancer. So, for example, the tissue type epithelial tissue would be carcinoma, as opposed to maybe other kinds of tissue which are going to be labeled accordingly. Malignant tumors are different. The cells in the malignant tumor are different than the cells surrounding. So that initial cell that misdivided or that didn't replicate correctly and caused this abnormal cell, the malignant tumor cell probably doesn't look very much like that original cell. So they're not very much like the normal adult cells we have in our body. They may divide rapidly, so they can grow quickly and have a large tumor in a short period of time, or spread throughout the body quickly, so that the patient has a very vast type of cancer before we even know it and can identify it. A good example of this is ovarian cancer, where the patient may not even have symptoms that they have a tumor until it's very well spread throughout the abdomen and maybe even metastasized to other organs in the body. The tumor may not have clear boundaries to it, and especially in your malignant tumors, they don't have clear boundaries, and they can send little legs out into the surrounding tissue. Now, the purpose for this is so that they can invade the surrounding tissue. This is where the term cancer comes from, is these legs that spread out from the tumor and kind of looking like a crab. They don't perform the normal functions of the organ. However, they may perform some of the functions, such as secreting hormones, and they may over or under secrete these hormones, which can cause then an endocrine problem with your patient, in addition to having this tumor. And that may be the thing that brings the patient to the hospital, is because they're having the symptoms of an endocrine problem rather than having any kind of symptoms maybe of a cancer. They can compress and destroy surrounding tissues, causing damage to those tissues or causing the dysfunction of those tissues. Now, that may sound kind of benign in some ways, but if you think about those tissues as being brain tissues or maybe being pancreatic tissues or liver tissues, of course, that's going to cause a big problem in the patient's functioning. This picture is showing your different tissue types and how they change as the patient is developing this neoplasm. So on the left-hand side, we have the normal tissue there. There's our normal mucosa, really nice mucosa of the gut. Now we're starting to see some dysplasia. See how the cells are changing on the second slide with dysplasia. So we don't really have any kind of a tumor forming there or anything yet. We just have some abnormal cells. This could be something that is benign and could simply repair on itself, or it may not be. Now we have these abnormal cells, these cells that have not only changed a little bit, but they're now vastly different than the underlying cells of the mucosa, and that's forming our neoplasm, our new growth. So you see that with the blue cells that are forming in the diagram, and then even the lighter colored blue cells, which are even more undifferentiated, and they start to invade the underlying tissues. So you notice the mucosa there, and now we're going down through the mucosa and into the muscular layer of the gut and into the submucosa when we get that invasive neoplasm. Now this diagram helps to highlight some of the hallmarks of cancer that make cancer cells different from other cells in the body. One is the self-sufficiency and growth signals. So it has its own growth signals that are regulating how much this particular cell type is going to grow, rather than relying on signals coming from the surrounding cells or from hormonal controls or other controls that we have in the body that normally would be signaling that cell to grow or stop growing. Then there is the insensitivity to anti-growth signals. So there are anti-growth signals that normally would tell a cell, hey, okay, we don't need any more of you, you're doing great, you're just the right size, you're just where you're supposed to be. But these anti-growth signals are coming to that cancer cell, and the cancer cell is ignoring them or is insensitive to them in some way. They evade apoptosis. So rather than having the normal programmed cell death so that these cells can be replaced by normal cells, cancer cells ignore or evade apoptosis, and they continue to grow, they continue to survive, despite the fact that they should be replaced and they should be rid of. They have limitless replicative potential. So the cell can just keep replicating and replicating and replicating without having any kind of control on the amount of replication that occurs. So that's why we can end up having either very diffuse cancers throughout the body, or we can have really large tumors that will form in some patients. We have a sustained autogenesis, and angiogenesis is the method by which the body makes new vasculature. So we have a sustained ability of this cancer tumor to make its own vasculature to feed itself. So this is an important component of a cancer tumor, that it's able to make its own vasculature because there's lots of cells in there that need to be fed, and so that it can feed itself and continue to grow. Lastly, we have tissue invasion and metastasis. So the cells start to invade the surrounding tissue first, and then they will start to spread throughout the body, and then they can cause the patient to have metastasis. So let's answer this question here. Which feature is characteristic of a malignant tumor? Is it that it grows slowly, it has a well-defined capsule, has a high mitotic index, or is well differentiated? Of course, the correct answer there is letter C. It has a high mitotic index. And the process by which a cell acquires specific new observable characteristics is called what? Is it commitment? Is it differentiation, commutation, or consanguination? Of course, the correct answer is letter B. It's differentiation. The process by which a cell acquires specific new observable characteristics is differentiation. Okay, some of these cancer cell properties we've already talked about, but let's talk about it in terms of the cancer stem cell. So this is going to be the non-differentiated cancer cell, and what it can do then to differentiate, or how it's different from our normal cells. So it has autonomy. It's independent from the normal controls of the body and is limitless, and its ability to be able to differentiate and to be able to continue to divide and to make more cells and form into more tissues. So it has a limitless potential here, whereas normal cells have some kind of potential on them where they're not able to continue to form and form and form. In other words, if we were to have a limitless control of autonomy of, say, a red blood cell stem cell, what would end up happening is we'd have so many red blood cells that our whole body would turn into just a big red blood cell. And of course it doesn't. There's limits on the amount of red blood cells we will make. There is a loss of differentiation, so there's no specific function to that cancer, although in some cases that cancer can take on functions of the cell type that it differentiated from. So for example, maybe there is a cancer that is forming on the adrenal gland, formed from adrenal tissue initially, and that adrenal tumor is secreting some of the hormones that we would get from the adrenal gland, like corticosteroids and our catecholamines. There's an irregular size, irregular shape to our cancer cells. They can replicate often like immature cells without having any kind of particular function to them. They invade other tissues. We talked about some of those components already. They can self-renew and create new stem cells. Stem cells are a type of cell that's pluripotent, which means it can differentiate into multiple different types of cell types. So a stem cell is going to be a cell that can differentiate into different types of cells in the body. For example, our pluripotent type of stem cell here can differentiate into blood stem cells or into other stem cells that will form other tissues, bone, nerves, and muscle. Cancer-causing mutations that will cause a fairly normal type of a tissue to turn into a cancer type of tissue. Some of the things to understand here is that it's predominantly a disease of aging. So we do have some cancers that form in younger people and in fact in children, but the vast majority of cancer is going to affect the elderly population, and that's because we have more time for these mutations to occur. So we can have proliferation or expansion of a mutation which causes the person to have this increased growth rate or decreased apoptosis, which then causes the overdevelopment of this neoplasm, this new growth, or this tumor. Multiple mutations usually are going to be required before the cancer can develop. So if we just have one little mutation, oftentimes the body will sense that and say, oh, that's an abnormal cell, let's get rid of it, and we never have a cancer form. But when we get multiple mutations, then that cell may be the same enough as normal tissue that the body can't sense it to kill it, but on the other hand, it's different enough that it can form into this new tissue that is not going to be destroyed by the body, and it can form into a cancer. Angiogenesis is the process by which new blood vessels grow. Now, in this particular case here, we're talking about the growth of new blood vessels around a tumor. So some tumors, and many tumors actually, are able to initiate the growth of new blood vessels in order to be able to feed themselves. So here we have a tumor, and the tumor is sending out these angiogenic factors in order to be able to form new blood vessels. So here the blood vessels around that tumor, and the blood vessels are actually forming so that they can go to the tumor and feed the tumor, and now the tumor can grow much, much bigger because it has its own vascular supply. Okay, just think of some of the ramifications of this. If that tumor, in fact, becomes large enough that it has a big enough vascular supply, the person's going to start having decreased perfusion to the rest of their body and may have symptoms elsewhere in the body of decreased perfusion as a result of this tumor basically kind of hogging up all the blood and taking the blood that normally would be in the rest of the circulation and feeding itself with that. Now also, of course, the tumor, if this tumor is taking the blood supply and it's taking proteins and vitamins and minerals out of the blood, that means it's going to be feeding itself while at the same time the rest of the body is not being fed. So that's what often leads to the patient developing things like weight loss and those kind of situations that we see in patients who have cancer. They start losing weight because this tumor is using up a lot of the nutrients that normally would be going to the rest of the body to maintain the rest of the body. We probably all heard a lot about cancer and genetics and having a genetic predisposition for developing cancer. As a matter of fact, many of you may have recently read about the situation with Angela Jolie, who had a bilateral mastectomy due to the fact that she had a certain type of marker, a certain type of cancer marker in her bloodstream, which could lead later on to her developing breast cancer. So we can look for some of this stuff. We can look for some of these kind of genes and do genetic testing on people to be able to find out whether they may have the potential for developing a cancer later. Now, that doesn't mean that everybody will, but we can get a pretty good idea of who may develop, like in this case here, who may develop breast cancer based on looking for a specific gene type. Now, that's not the end all. Of course, even if you're not expressing a particular gene, you could still develop cancer. But there is a genetic link in many cases, and we can look for that genetic link to help us to be able to determine who may and may not be at the highest risk for developing cancer. So oncogenes are used in the process of having a normal cell division occur, but they may cause that cell to produce some abnormalities. For example, too much protein, or maybe an abnormal protein is produced, protein that turns on and off all by itself, or a protein that is made when it's not needed, or that cannot turn the cell division off, or that may be made by a different, or should be made by a different cell. So there's a lot of things that this oncogene can cause that normal cell to do that would be abnormal. So here's some mutations that can cause a person to develop an oncogene. It could be a point mutation. We talked about these earlier when we talked about genetics and translocations. We talked about gene silencing and some of those different things that can occur that would cause the person to have an abnormal gene, an abnormal type of break in the chromosome, and have new genes that are formed that are not the normal genes that we would normally have. So these are some of the things that happen with our gene mutation that then cause the person to develop this oncogene, and the oncogene then goes into the normal cell division and causes an abnormality to occur, which causes something else that's abnormal to happen within that cell. Now, that cell may look perfectly normal for right now, but it's doing something abnormal, producing some kind of abnormal protein or something that will later cause the person to potentially develop cancer. So we can do some typing of our genes to try and find out whether or not somebody has the potential for developing a certain kind of cancer. For example, let's drop down to the bottom of the list there, and it talks about breast cancer, looking for the BRCA1 and 2. Those are gene types that are associated with breast cancer. So, and the same is true with the other ones that are listed there. These are gene types that are listed with a specific type of cancer that we may want to test for in order to be able to find out if that person's going to express that and possibly have a high risk for developing cancer. So when would we do this? We don't just run out and we do, run these tests on everybody, but in certain people, maybe if they have a strong family history. So if you have a family history where your mother and your aunt and your grandmother and your sister have all had breast cancer, well, certainly it'd be worthwhile to have that genetic testing done to find out if you're expressing that gene and maybe at a high risk for developing breast cancer. But we don't do this with everybody. It's those people who may run a high risk based upon the history of the family and other social history. So here we have the different types of mutated genes. We have our normal genes there at the top. And again, we're going back to that colon, so that colon tumor, the normal colonic epithelium there. And then we have some cells that have kind of had some abnormal division going on here. So there was a little bit of a problem with our cell division, and we have cells that look normal, but they're a little bit abnormal. Now we go down and divide even further, and you see that some of those kind of abnormal looking cells just kind of stay the same. And they break off into cells that are going to continue to be slightly abnormal. But then we have over to the right, the kind of purplish looking cells there that are forming an adenoma. So those are cells that have now become even further differentiated and further from the original type of colonic epithelium. Okay, further on down here, now we're getting some loss of more genes, and we're getting a larger adenoma, and the cells are starting to look abnormal. Eventually now we're going to have more of our abnormality occurring during the division, and now we have an invasive carcinoma. So we started out with a normal cell, and it was the process of dividing the cells and trying to maybe just renew our normal mucosal lining that resulted in this abnormality in the division, which then resulted in further abnormality of finally getting to the point where we have an invasive carcinoma. So the telomere may have something to do with this process by which cancer can form as well. Telomeres are the protective caps on your chromosome, and we only have a limited number of these, but they become smaller and smaller with each cell division. So because they become smaller and smaller with each cell division, it leads to the possibility where we could have an abnormality occur with our cell division as a basis, or having the telomere as a basis for that. So these are a couple examples of people who have particular types of tumors, and this is the retinoblastoma. Again, these are really extreme cases here. The types that we have in our pictures in the book are really pretty extreme cases. Usually we're going to find these problems before they get to be this kind of a situation. So the best explanation for higher rates of cancer in older populations is A, aging cells are more susceptible to mutation, B, the development of cancer requires several mutations over time, C, older individuals have higher rates of tobacco use, or D, the elderly show increased rates of apoptosis. Our correct answer is, of course, letter B, the development of cancer requires several mutations over time, and that's the best explanation for higher rates of cancer in the older population. There's also the possibility that there may be a viral or bacterial cause that is causing that normal cell, when it divides, to become abnormal. So this infection is setting up a situation with inflammation whereby which, when the cell divides, it is not dividing normally. About 15% of all cancers can be linked to a viral infection. This could be hepatitis, this could be Epstein-Barr virus, it could be Kaposi sarcoma, or it could be HPV. So all of those things are associated with the development of certain kinds of cancers. It can also be bacteria. H. pylori has a high correlation with developing a gastric cancers. So peptic ulcer disease and stomach carcinoma are associated with H. pylori infection. That's a bacteria. Inflammation, and of course infection can cause inflammation, so maybe those infectious processes we just looked at are really linked to cancer because of inflammation. But at any rate, inflammation can have a link to cancer as well, especially chronic inflammation. So if you have a situation that's causing a chronic inflammation in the body, a patient maybe who has an arthritis condition or has some other kind of chronic inflammatory condition. And the reason why is because we have cytokines released from our inflammatory cells, and we also have the production of these things called free radicals. We talked a little bit about those earlier when we talked about altered cellular biology and ischemia, injury, and necrosis, which also develops free radicals during the process of reoxygenating a tissue. Free radicals are oxygen radicals, abnormal oxygen molecules that are actually manufactured by white blood cells in an attempt to try to kill off bacteria. However, if we have these things produced in excess of our normal antioxidants, then what will happen is the free radicals start to kill healthy tissue, or maybe possibly could cause a damage to a healthy tissue, making it abnormal so that it could have a mutation potential. You're going to hear cancer talked about as being in stages. And the reason why we use this terminology is so that we have a good way to express to each other as to how far along the cancer is in its process of invading other organs and metastasizing throughout the body. So that's why we're looking at this as far as our staging goes. So it's based upon the pathological study and clinical findings that we see in our particular patient. Let's take a look at our stages then. Stage 1 is cancer that's confined to the organ of origin. So we have a tumor, it's confined to one specific area, it is not invading the local tissue. Now stage 2, we have a locally invasive type of a tumor. So now the tumor is starting to dig down into the tissue of its host organ. Stage 3, now we're spreading to the regional structures. So now we've moved out in maybe the lymph nodes or maybe some adjacent organs. We're moving into areas that are adjacent to that tissue. Stage 4, we've spread to distant tissues. So for example, maybe the patient has breast cancer that is now spread to the lung and the brain. That would be stage 4 or metastasis. In addition to using our staging system, we can also use the World Health Organization's TNM system. T stands for the tumor spread, has it metastasized or not. N stands for node involvement, are the nodes involved or not. And M for the presence of distance metastasis. So the diagram illustrates the TNM staging that can occur. So our tumor, and we look at let's start with T, the tumor. We look at the local tissues in the organ. There's nothing going on there, so that's a 0. 1, we have the tumor within the organ of its origin. 2, it's starting to invade out into the tissues around it, but has not expanded through. And then finally, now you see T3 would be a tumor that is spreading out through that original organ and into the local tissues. Nodes, we have no node involvement with a 0. We have a slight node involvement with a 1, so there's some local nodes that are involved. Now we have some fixed nodes involved, and that's going to be an N2. Then metastasis, we have none with a 0. Okay, we're going to have some demonstrable or suspected additional metastasis throughout the body when we get to the 2. So as has already been described, we can have a local spread, which is just to continuous organs that are around the same area. We can have metastasis to distant organs, so we're spreading from that original organ out into the lymphatics, into the bloodstream, so to distant sites. Maybe the original site was the liver, and now it's up into the brain. Okay, that's a distant site. That's away from the original organ. There seems to be a specific preferential growth of cancer cells in certain organs. So metastasis will tend to happen from certain types of cancers to certain organs in the body. So this picture is just showing the primary tumor and how those primary tumor cells are managed to escape. They got into the bloodstream, and there's some host lymphocytes, there's some platelets, etc. that are carrying those tumor cells to the area where they're going to escape to that additional organ system that they're going to kind of enter into. So they escaped out of the primary tumor, went through the bloodstream, got to this distant organ, and escaped the vasculature again so that they could start to proliferate in that particular. Some of the common sites of blood-borne metastasis include the bone, the brain, the liver, the adrenal glands, and the lung. So those are some of the common sites that we're going to see metastasis occur. Tumor markers give us the opportunity to be able to look for specific tumor types in patients. So let's say that your patient's had cancer, was treated with chemotherapy, and we want to just follow up with them and make sure that that cancer still has not come back, that it has not reoccurred. Well, one way to do that would be to look at these tumor markers. An example is CEA, carcinoembryonic antigen. This is something that is commonly used as a marker of cancer, and we're going to look at that to help to tell us about whether or not the cancer has reoccurred in a patient. This might be also a good kind of initial screening type of a tool if we're thinking maybe that the patient has cancer. The most common route of metastasis is through the arteries of body cavities, lymphatics, or connective tissue. Of course, the correct answer would be lymphatics. The most common route of metastasis is through the lymphatic system. Environmental risk factors are important for the development of cancers. So having certain things in our environment will also potentially cause the patient to have mutations that can cause cancer to develop in their body. So we want to be aware of those risk factors. One of the most common ones, and certainly if you hear about a risk factor, you have a risk factor on one of your exams, I would certainly pick tobacco in most cases. But tobacco is definitely has the ability to be able to potentially cause cancer in patients. Now keep in mind, these are these are risk factors. So these are things that potentially could cause the patient to develop a cancer. It doesn't mean it's going to happen every time. Not everybody who smokes is going to develop lung cancer, but certainly it does predispose somebody to developing cancer. Tobacco is linked with cancers of the lung, the lower urinary tract, the digestive tract, the liver, the kidney, the pancreas, the cervix, and the uterus. Wow. And it's also linked to leukemia. So I think we think about tobacco and cigarette smoking as just being linked to cancer of the lung, but it also predisposes your patient to developing a number of other cancers as well. Oxidizing radiation, such as X-rays, can also cause the patient to develop having cancer. So that's one of the reasons why we want to try and limit the amount of X-rays we get during our life, and we don't want to have unnecessary X-rays because of the possibility of potentially causing cancer at some point. Ultraviolet radiation, such as laying out in the sun, of course that predisposes you to developing skin cancer. So we can have some alterations occurring in the skin cells as a result of being exposed to ultraviolet radiation. Alcohol consumption increases the possibility of developing an oral cancer, pharynx, larynx cancers, esophageal cancer, and liver cancers. And the combination of alcohol and cigarettes together definitely increases the risk of some of these like oral cavity cancer, pharynx, larynx cancer, and lung cancer. Also, the patient's sexual reproductive behavior, having the patient having recurrent sexually transmitted diseases increases the risk that that person is going to develop a type of a cancer and high risk for HPV. Well, physical activity can both be a good thing and a bad thing. If we lack physical activity, that's certainly going to increase our cancer risk. So having good physical activity and exercising is going to increase or reduce our insulin and insulin-like growth factors, decrease the possibility of obesity and inflammatory mediators, free radicals, and increase our gut motility, which will decrease the amount of time that maybe some of these cancerous type of agents are in contact with the gut that could be potentially causing cancer of the GI tract. We also have occupational hazards such as asbestos, not so much anymore, but those things certainly have been present in the past that could cause a patient to develop cancer. Well, you've probably heard about dietary risk factors for the development of cancer as well. There's certain things we can be eating in our diet that increase the risk of developing cancer. These things are called xenobiotics, and they're going to be toxic kinds of things that we eat that are going to potentially cause the possibility of developing cancers. Obesity. So cancer is going to correlate with BMI and have a higher risk of cancer the higher our BMI is. Now, that, again, remember, these are risk factors. So that means there's a higher potential for developing cancer. It doesn't mean that your patient's going to have these things if they have cancer. So don't think about these as being definitive, like, okay, if the patient's got this, they're going to develop cancer. It's not necessarily going to happen, but there is a higher risk when these things occur. So the more obese your patient is, the greater the risk they are going to develop certain kinds of cancer, like colon cancer, breast cancer, pancreatic, and endometrial cancers. The most important environmental risk factor for cancer is exposure to ultraviolet radiation, radon, estrogen, or cigarette smoke. Well, of course, you always got to pick the cigarette smoke on this one here. Environmental risk factor, definitely cigarette smoke. We want to make sure that we're eliminating that from our patient's life if possible. Well, let's talk a little bit about the clinical manifestations of cancer. So how does somebody know if they are developing cancer? You know, you don't always have this big tumor on the outside of the body, like some of those pictures we saw, the retinoblastoma and the neurofibromatosis. You know, you often see those huge kind of things on the outside of the body. So oftentimes what we have to do is to look for more subtle signs that the patient is developing cancer. Pain, obviously, is one thing we often hear associated with cancer, and we hear of people having this severe pain with cancer. Well, cancer oftentimes is going to grow, and that tumor is going to get bigger and bigger and bigger without the patient ever having any pain. So literal no pain in the early stages, even with malignancy. However, there can be, obviously pain is influenced by a number of different things that can be associated with cancer. So fear. So now the person learns that they have this diagnosis of cancer. What do you think happens to their pain perception? Well, it goes way up because of fear, anxiety, maybe sleep loss, fatigue, all those things. And now they're starting to get that overall physical deterioration that's occurring as well. Some of the mechanisms that contribute to the person developing cancer pain include pressure, obstruction, invasion of the sensitive structures inside the body that contain nerve endings, stretching of our visceral surfaces, so we're starting to stretch the organ on the inside there, and that's causing pain. Tissue destruction, inflammation, so all of those components are potentially causing stuff happening inside the body that's going to cause a person to have pain. Let's take one of those, for example, stretching the visceral surfaces. You ever have a situation where maybe you've got a GI infection or something like that, and you just kind of really bloated, and that bloated feeling makes you feel uncomfortable, maybe even painful. Now, obviously, tissue destruction. Whenever you have a destruction of tissue, that's going to hurt. But inflammation is painful. So if you've ever had an inflamed joint, or if you've ever, twisted an ankle or something like that, where you've had inflammation occur in the area, you know that inflammation is painful. Fatigue is another clinical manifestation of cancer and can be the result of a couple things. Remember, we had that tumor that's building its own blood supply and it's taking away nutrients from the rest of the body. This can cause fatigue. So the patient could have fatigue from that. It can also be a problem where the cancer is starting to deplete some of the other important nutrients or the other important things in the patient's body, maybe like hormones and things like that. Other suggested causes for fatigue could be sleep disturbances, biochemical changes from circulating cytokines. So we're getting inflammation that's occurring as a result of this cancer, and that's causing the person to feel fatigued. Disease in the treatment itself. The treatment can cause fatigue. Chemotherapy is very fatiguing. Radiation therapy is very fatiguing. The person now is not getting up and moving around as much. That causes even more fatigue. The lack of nutrition. This patient may not feel like eating, especially if they have a cancer of the GI tract or the upper airway. They may not feel much like eating, and their nutritional status may not be good. Even patients who have cancer of other parts of the body, for example, ovarian cancer, and we're giving chemotherapy, that's going to be a situation where the patient may not feel like eating because the chemo is causing irritation to the GI tract. Cachexia is a severe form of malnutrition, and they say it's present in about 80% of cancer patients at death. And this patient here, obviously in the illustration, is very severely malnourished as a result of having cancer. And, at this point in time now, the person just can't get enough nutrients in order to be able to build the muscle mass back and to build some of those fat stores, etc. So at this point, it's very difficult to try to be able to restore some of the patient's ability to be able to get up and carry out their ADLs, etc., because they're so wasted away. Their muscles have wasted, and they don't have fat in order to maintain their heat in their body and things like that. Other clinical manifestations include anemia, so we can have a decrease in the amount of hemoglobin that we see in the blood. A couple things causing this. It could be the malnutrition that's causing this. It could also be that we are starting to use up our red blood cells, or we're having some kind of a malignancy in a blood-forming organ such as the bone. We can have a paraneoplastic type of syndrome where the patient is having local and distant spread of the tumors, and we're having hormones released as a result of that primary tumor. We can have leukopenia, so we're having a decrease in the number of white blood cells, or thrombocytopenia, where we have a decrease in the number of our platelets as a result of having bone marrow invasion of our tumor and decreasing or having toxic effects to the bone marrow. We can also have an increased risk of infection. Just the fact of having cancer decreases our immune response, but having cancer and then having chemotherapy or radiation therapy for that cancer will decrease our immune response even further. So infection risk is obviously very important here as well. The GI tract may be involved, and we may have decreased cell turnover because of a loss of protective barriers within the GI tract. We may have malabsorption and diarrhea from some of either the cancer itself or from the treatment. So again, let's go back to chemotherapy. Chemotherapy is going to kill rapidly dividing cells. Well, rapidly dividing cells also happen to be in the GI tract. Okay, so that's going to be an area where we may have some destruction of new cells being produced in the GI tract, and that's going to cause the patient potentially to have some problems with absorbing nutrients and even feeling like they're hungry and they want to eat. So we have here a 50-year-old female who's suffering from anorexia, anemia, asthenia, weight loss, altered metabolism, all resulting in malnutrition. She was previously diagnosed with cancer. Which of the following describes her symptoms? A, fatigue, B, cachexia, C, paraneoplastic, or D, acute phase response? Well, the correct answer is B. This is a good example here of cachexia. Let's take a look at this scenario here. We have Mrs. T has liver cancer. Her doctor did an initial molecular diagnosis and put her on targeted therapy, targeting to that type of a tumor. The tumor shrank by almost 75%. 2 years later, the tumor was growing again, and this time it did not respond to the drug. Last year, she was diagnosed with metastasis in her femur that has not responded to the drug either. Mrs. T wants to know why the cancer cells stopped responding. Are they not all the same cells? Okay, well, yeah, it's the same cell type, but it has adapted so that it's no longer going to be sensitive to the type of drug that was given in the initial treatment. So we may have to adjust the way we're treating our patient based upon the response that we're getting to our therapy. And in a situation like this patient probably had time for the tumor to adjust. Remember, these cells are very adaptive in order to try to maintain their growth and maintain their viability. Other manifestations of cancer, we can see changes in organ function related to damage directly to that organ or by inflammation or even failure of that organ because of the cancer itself. We can have local effects of tumor, for example, compression of nerves or veins or GI tract causing a gastrointestinal obstruction. So we can actually obstruct the intestinal system because we have this tumor in there that's obstructing it. We can have ectopic hormones that are secreted by the tumor cell cells. So the tumor cells themselves can secrete hormones that may mimic some other function in the body. We can have nonspecific signs of skin breakdown. We can have muscle wasting and bone breakdown as a result of this cancer that is breaking down tissue. Well, obviously, the worst case scenario would be that the organ fails as a result of having a cancer, but we can also have benign tumors that would cause an overproduction of normal organ secretions. So we may have a benign tumor that's sitting in the organ that's just causing the organ, or it looks like at least that the organ is overproducing what it's supposed to be doing. So we could have a thyroid tumor that is overproducing thyroid hormone, and then the patient looks like they have hyperthyroidism. Malignant tumors may occasionally cause an overproduction, such as in thyroid cancer, but commonly decrease the production of normal organ secretion. So usually they're going to suppress the organ rather than to cause it to overproduce. A malignant tumor would, whereas a benign tumor may cause the overproduction of normal organ secretions. So the tumor is growing in the patient's body, and we can see a number of different local effects from that tumor, including bleeding. So there can be bleeding locally because the tumor is disrupting the normal blood flow to those tissues. We can have compression of blood vessels, such as a superior vena cava syndrome, where we have a tumor in the upper chest. It's compressing the superior vena cava, and the patient's face and head will swell when they lay down at night to sleep, and when they get up during the day, because of gravity, the blood is allowed to flow out of the head and the swelling will go down by the end of the day. We can also see portal hypertension, which can then lead to the patient developing gastrointestinal bleeding, such as is caused by esophageal varices. We can have compression of our lymph vessels, causing edema, ascites, and effusions to different parts of the body, so we can see that occurring. We can have compressions of our hollow organs. One of the largest hollow organs in the body is going to be the GI tract, so we can see some severe problems here in the GI system, or compression of nerves, which can cause either pain and or paralysis occurring in the patient. So paraneoplastic syndromes are syndromes where the cancer cells will produce hormones or hormone-like proteins such as ADH, parathyroid hormone. So those kind of things are produced by the cancer cells. So it looks like, for example, that too much ADH is being produced by the pituitary, and the patient's developing an SIADH kind of situation, where in fact it's the tumor that's causing this and not a problem with our neurologic function or our neurologic status. They can also produce proteins that will affect our clotting. As a more generalized type of a thing, cancer can cause this cachexic syndrome, where the patient has weight loss, muscle wasting, weakness, anorexia, and even anemia. So let's take a look at those just a little bit. Weight loss, okay, the tumor is using up the proteins and the nutrients in the body that can normally be used for other tissues. That would also cause the muscle wasting. This diagram is illustrating what could happen with this cachexic syndrome, where the patient is developing all sorts of systemic problems as a result of having cancer. So we have the brain is being stimulated by these cytokines that are going to cause anorexia. The reduced substrate supply to the body is then going to cause skeletal muscle wasting. We also have the cytokines causing a direct catabolic effect on our skeletal muscle, causing wasting. That then is going to cause an increased substrate demand for amino acid, and we're going to start to be using up our proteins from the liver. So we have these acute increase in phase proteins, and increase in our urinary nitrogen loss is going to start to occur. So this all is occurring as a result of cytokine formation caused by the systemic inflammation produced by the tumor itself. Well, hopefully this information was helpful, in addition to the information you have in your book, to help you to understand a little bit better about what's happening with cancer and the biology and the pathophysiology of cancer and how it can manifest itself in your patients, and some of the things we may do to try to treat it in order to keep it from expanding and causing more problems for our patient. So this is Biology of Cancer. My name is David Woodruff. Thanks for joining me this time, and until next time, bye now.